Hello everyone, it's Dr. Locklear here, and I'm coming to you again with the concept of cellular regulation, and we're going to be talking about Exemplar 2I, skin cancer, and that starts on page 133. So our outcomes for this chapter, we want to look at what causes skin cancer, how does it occur, the causes, the risk factors. It is preventable. So what are some of the things that we can do using, sunscreen and limiting your exposure to tanning beds and things of that nature. What are the clinical manifestations? And there's some vivid pictures in this chapter here that shows you different types of skin cancer. How is it diagnosed, and how does the collaborative team come together to treat people with skin cancer? Melanoma can metastasize. It is very serious. It's one of the most dangerous cancers that's around. What are the considerations of patients with skin cancer across the lifespan? Children through adults. And then how do we use the nursing process? One of the things that you'll see in this chapter is when you are assessing your patient that you need to ask them to fully undress so you can look at every part of their skin, examine it closely, document the number of moles, the number of darkened moles, skin crusty lesions. Assessment and documentation is going to be very important with this type of patient. So let's get started. So the skin, despite its ability to protect the internal body from external damage, is a fragile organ and is subject to damage from UV radiation and chemicals. And we know that the skin is our outer protection of everything that's on the inside of us. Our skin is the first line of defense against infection. And so if there's damage from UV radiation and chemicals, it can alter this protection to our body. Over time, this damage may result in alterations in cellular structure and function, leading to malignancies of the skin, otherwise known as melanoma. The skin is a common site for malignant lesions. Many of these lesions are found on skin surfaces that have undergone long-term exposure to the sun or the environment. So being out in the sun, and as you see in the picture here, UV radiation, sunburn, ultraviolet rays, all of these can cause the skin to change and cause these malignant skin tumors or melanomas. They're the most common of all cancers. The non-melanoma skin cancers are basal cell cancer and squamous cell cancer. So what's the pathophysiology? They're classified into melanoma or non-melanoma. The melanomas, these arise from melanocytes, cells located at or near the basal layer, the deepest epidermal layer of our skin. These cells produce melanin, the dark skin pigment. Melanin is made in granules and transferred to keratinocytes, primary cell of the epidermis, or keratin, where it accumulates on the superficial side of each keratinocyte and forms a shield of pigment over the nucleus as protection against the UV rays. Malignant melanomas can develop whenever there is pigment, but about 1/3 of them originate in existing nevi or moles. So if you see people that have a lot of moles, they may be susceptible to more skin cancer than somebody who does not. Almost all malignant melanomas are more than 6 millimeters in diameter, are asymmetric, and initially develop within the epidermis over a long period. While they are still confined to the epidermis, the lesions, called malignant melanoma in situ, are flat and relatively benign. However, when they penetrate the dermis, they mingle with blood and lymph vessels and are capable of metastasizing. That's why it's so dangerous, because our skin is so vascular and every part of our skin gets blood supply, so the metastasis can be very great. At this later stage, the tumors develop a raised or nodular appearance and often have smaller nodules called satellite lesions around the periphery. The prognosis for survival among people diagnosed with malignant melanoma is determined by several variables, including tumor thickness, ulceration, metastasis, site, and the patient's age and gender. Younger patients and women have a somewhat better chance of survival. Tumors on the hands, feet, and scalp have a poor prognosis. Tumors of the feet and scalp are less visible and may not be diagnosed until they grow into the dermis. So again, doing a thorough assessment of the entire body, you've got to really look. Don't be quick with your assessment if you're specifically looking for skin issues. So we have some things listed here as precursor lesions. Congenital nevi are present at birth. Some lesions are small, others are large enough to cover an entire body. Their color can range from brown to black. They are often slightly raised with an irregular surface and a fairly regular border. Dysplastic nevi are also called atypical moles. Although dysplastic nevi are not present at birth, they appear as normal nevi during childhood and become dysplastic, or in other words, having abnormal development after puberty. A patient with classic dysplastic nevi has more than 100 nevi, at least one of which is larger than 8 millimeters in diameter, and at least one of which has the characteristics of malignant melanoma, which is asymmetry, irregular border, color variation, and a diameter greater than 6 millimeters. A familial tendency to dysplastic nevi increases the risk for development of malignant melanoma. However, it is not known whether people with dysplastic nevi and no family history of melanoma face a higher risk. Dysplastic nevi most often appear on the face, trunk, and arms, but are also seen on the scalp, female breast, groin, and buttocks. The pigmentation of the nevi is irregular, with mixtures of tan, brown, black, red, and pink. An area of lighter pigmentation is surrounded by a papular area of deeper pigmentation, described as a fried egg appearance. The borders of the nevi are irregular. And then you have lentigo maligna, also called Hutchinson freckle, is a tan or black patch on the skin that looks like a freckle. It grows slowly, becomes mottled, dark, thick, and nodular. It is usually seen on one side of the face of an older adult who has a large amount of sun exposure. And here's a picture on page 135 that would represent the lentigo maligna. So what are the classifications? You have superficial spreading melanoma, and it's the most common type. It's usually flat and scaly or crusty and are approximately 2 centimeters in diameter. They often arise from a pre-existing nevi. You can see them on the trunk of men and legs of women. Lentigo maligna melanoma. This often arises from the precursor lesion, lentigo maligna. The lesions are large, tan with different shades of brown, and they make up on the areas of that have had long sun exposure, such as the face, neck, and sometimes the dorsal surfaces of the hand and the lower extremities. It's characterized by a proliferation of atypical melanocytes parallel to the basal layer of the epidermis, and their growth may last 10 to 25 years. And then nodular melanoma. These are lesions that are raised, dome-shaped, blue, black, or red nodules on the areas of the head, neck, and trunk that may or not have been exposed to the sun. The lesions may look like a blood blister, or they may ulcerate and bleed. And then nodular melanoma has only a vertical growth phase, but it grows aggressively during that phase. The absence of a radial growth phase makes this typical melanoma more difficult to diagnose before it metastasizes. And then there's acral lentiginous melanoma, is the least common, comprising less than 10%. It's also called mucocutaneous melanoma. It's less common in people with fair skin and more common in people with dark skin. The lesions progress from tan, brown, or black flat lesions to elevated nodules and are about 3 centimeters in diameter. So what are the some of the uh, non-melanoma skin cancers, and these are listed on page 135. You have basal cell cancer is an epithelial tumor that is believed to originate either from the basal layer of the epidermis or from cells in the surrounding dermal structures. They're characterized by impaired ability of the basal cells of the epidermis to mature into keratin or keratinocytes with mitotic division beyond the basal layer. This results in a bulky neoplasm that grows by direct extension and destroys surrounding tissue, and it gets into the nerve and the blood vessels and the lymphatic system, and we know from other lectures that once it's in the lymph system, it can travel throughout the body. Tumors greater than 2 centimeters in diameter have a higher reoccurrence rate. And then you have nodular basal cell carcinoma. It's the most common type, appears on the face, neck, and head. It's made up of masses of cells that resemble epidermal basal cells and grow in bulky nodular form, and it grows in stages. And in the early stage, it looks like a smooth pimple, and then roughly around 6 to 12 months, the tumor will grow and it can double in size. The skin over the tumor is shiny, pearly, white, pink, or flesh colored, and you may have telangiectasis, and that's not really how you say that. It's I'll have to look that up and repeat it for you in class. It's hard to pronounce that word. Anyway, what those are those little red, purple, or blue discolorations. They look like little red blisters on your skin, and you'll know it when you see that. Superficial basal cell carcinoma, found most often on the trunk and extremities, is the second most common type of basal cancer. Pigmented basal cell found on the head, neck, and face, it is less common. Dark brown, blue, or black appearance. Morphiform basal cell carcinoma is the rarest form, and the tumor resembles a flat ivory or flesh-colored scar. And keratotic basal cell is found on the pre-auricular and post-auricular groove, and that's around the ear, auricular area. So a lot of people do get skin cancers on their ear. Squamous cell is a malignant tumor of the squamous epithelium of the skin or mucous membranes. It occurs most often on areas of skin exposed to UV rays and weather, such as the forehead, helix of the ear, top of the nose, lower lip, and back of the hands. Squamous cell cancer may also arise on skin that has been burned or has chronic inflammation. This is a much more aggressive cancer than basal cell, faster growth, and greater potential for metastasis if it is not found and treated quickly. The tumors arise when the keratinizing cells of the squamous epithelium proliferate, which means they grow, producing growth that eventually fills the epidermis and invades the dermal tissue planes. Keratization of some cells is present, and the formation of keratin pearls is common. The keratin formation diminishes as the tumor grows. As it grows, the tumor cells increase in number and rate of mitosis, forming odd shapes. Squamous cell cancer begins as a small, firm red nodule. It can be crusty or with keratin products. As it grows, it can ulcerate, bleed, and become very painful. The tumor extends into the surrounding tissue and becomes a nodule, and the area around the nodule becomes indurated or hard. And so, squamous cell is very serious. It's one of the most aggressive kind. Actinic keratosis is also called senile or solar keratosis and is an epidermal skin lesion directly related to chronic sun exposure and photo damage. Actinic keratosis may progress to squamous cell carcinoma. Because of this, the lesions are classified as pre-malignant. They are often shiny, may be scaly. The scales are removed, the underlying skin bleeds. And so with this, you may see multiple patches on the face, the dorsal of the hands, the forearms, and the upper trunk as well. The etiology, UV rays can actually damage the DNA in cells. This is believed to be the cause of most skin cancers. Now, don't get me wrong, we need sun to help us process vitamin D. We get our vitamin D, and we need that to strengthen our bones and to help our calcium get into our bones. But we don't need to overdo it. You only need about 15 minutes of sun exposure a day to get what you need. Although UV rays account for only a small part of the sun's radiation, exposure to UV radiation from sunlight is a major cause of skin cancer. Tanning beds are another dangerous form of UV exposure. Other factors are age, skin type, skin color, and genetics. And one of the things is people that have lighter skin tones may be more susceptible to skin cancer than people with darker skin tones. But let me say, anybody can get skin cancer. Risk factors vary according to the type of lesion. Melanoma, non-melanoma, and actinic keratosis each have specific considerations related to the risk factors. So the melanoma, although the exact cause of melanoma is unknown, certain risk factors are associated with the disease. See box 2-6, risk factors for melanoma skin cancer, and they're listed here on your slide as well. Non-melanoma skin cancers, some of the risk factors, including environmental factors and host factors. Unknown factors also play a role. The environmental factors are UV radiation, pollutants, chemicals, ionizing radiation, viruses, and physical trauma. Ultraviolet radiation from the sun is believed to be the cause of non-melanoma skin cancer. Sunlight contains both short-length rays and long-length rays. UVB rays are absorbed by the top layer of the skin and cause sunburn. UVA rays penetrate deeper into skin layers, causing tissue damage. Both types of rays are believed to cause DNA alterations and suppress T cells and B cells. And we need T cells and B cells to help us fight off viruses and infections. So when those are destroyed, we don't have anything to fight with. The amount of UV radiation reaching the Earth is increasing, most likely from depletion of the ozone layer by the planet. The U.S. Environmental Protection Agency, or the EPA, predicts that for every 1% decrease in the ozone layer, a corresponding 1 to 3% increase in cases of non-melanoma will develop. And that's important to know because as we go into these phases, where we're losing our ozone layer, we need to be more protected outside. And it goes on to talk about environmental and lifestyle factors, people who live in higher altitudes, certain chemicals, coal, tar, asphalt, soot, all those are listed, viruses, radiation, x-rays, and then skin pigmentation. The amount of melanin produced by the melanocytes determines an individual's skin color. The more melanin, the more the skin is protected from the damage produced by UV rays. For some folks, such as African Americans, Asian Americans, and people of Mediterranean descent, have a much lower incidence of non-melanoma skin cancer, whereas others that are fair-skinned, like Irish and Scandinavian and English, do not. Actinic keratosis. The prevalence of actinic keratosis is highest in people with light colored skin. The lesions are rare with people in dark colored skin. Prevention. Primary prevention includes avoiding prolonged sun exposure and refraining from the use of artificial tanning machines. Recommendations for protection from the sun's harmful rays include application of sunscreen that provides a sun protection of 15 or higher. Before extended periods of sun exposure, sunscreen that provides 30 or higher should be applied. And, every time you get in the pool or get into water, you should reapply the sunscreen because it will wash it off. It says here in your text it should be applied 30 minutes before anticipated sun exposure and reapplied every 2 hours. Or if you get in the water, you need to put it on as soon as you get out of the water. And it says that immediately after swimming or periods of excessive perspiration. Broad-rimmed hats, sunglasses should be worn. Some people may even need to wear long sleeves outside. They need to, protect their skin at all costs. Head to toe skin exams and avoid exposing newborns to direct sunlight. You have a safety alert on page 138, and I really like safety alerts because they're there for a reason. In the prevention of skin cancer, wellness promotion includes educating patients about the risk associated with indoor tanning devices. With just one indoor tanning session, an individual's risk for developing melanoma increases by 20%. With each additional tanning session during the same year, the individual's risk for melanoma increases by nearly an additional 2%. Tanning beds are so dangerous, especially for young individuals, that several times in the United States have banned the use of tanning beds by anyone under age 18. And that's important to know, and I think there's still like that. Clinical manifestations differ with the skin types, color, surfaces, borders. You want to look at the size, and you see unexplained weight loss, fatigue, skin changes, thickening or lumps, unusual bleeding, sores that do not heal, really dark moles, crusty lesions that may bleed easily, painful, and they get bigger. Collaboration, early detection, and prompt intervention. Teaching, teaching, teaching. It talks about the ABCD rule, and right here I have ABCDE on the screen. So asymmetry, one half of the nevus does not match the other half. Border irregularities, edges are ragged, blurred, or notched. Color variation or dark black color, and diameter greater than 6 millimeters, and then evolving. Any change in size, shape, or it's just growing. It looks like it's getting bigger. Diagnostic test, again, use the ABCD rule. Palpation of lymph nodes, delivering spleen to see if there's any type of inflammation going there. Microscopic examination of the skin lesions, biopsy of the skin lesions, test for metastasis, and microstaging. And it also lists liver function tests, CAT scan of the liver, CBC, serum blood chemistry, chest x-rays, bone scan, CT, or MRI of the brain. And these are additional things that they may do if there's metastasis. Microstaging, and this is on page 138, describes the assessment of the level of invasion of a malignant melanoma and the maximum tumor thickness. They use the Clark system of microstaging, and you can see down in figure 2-25 the Clark system. And so basically, the deeper the lesion, the worse it is. Okay, so make sure you read over that. Surgical excision, here's some pictures where may have been one little tiny mole, but when they get in there, it's deeper. And I had said that before. A lot of times it's deeper, and so they end up having to remove more skin. Look on page 139. It talks about the clinical manifestations and therapies of skin cancer, and it talks about melanomas and non-melanomas and the actinic keratosis. This is just a recap of what's in the reading, but I would read over this, okay? Immunotherapy, this is still being investigated, and the uses of immunotherapy. And so it can be done with other agents, a combination of treatments. And then they talk about using radiation. And you're thinking, well, why? That's why I got melanoma in the first place. Melanoma responds to higher dose radiation, especially if the tumor is small. So they have good results with it. It's specifically focused on the site of the cancer to stop the growth. Lifespan considerations, children, melanoma, most common pediatric skin cancer, but it is rare. More common in teens because, they're out more, they're at the beach, and, they're in college, and they're, going on summer breaks and things of that nature. Sun exposure and tanning beds also in the young adults as well. Older adults, incidence of malignant lesions increase. Most are basal cell, squamous cell, 10 times higher incidence of melanoma in the adults. Symptoms differ a little bit in the adults. The prognosis is poorer than in young adults because a lot of times they've had exposure for a long time and it's been growing up under the skin and maybe nobody or the person didn't realize that they had it. And so now when they get in there, it's a lot worse than they thought. So biopsies, not are all candidates for surgery. Sometimes the spread is too far gone. Radiation, comorbidities have to be considered, and skin assessments and education on risk reduction, which these are listed under your nursing process. Careful assessments, monitoring for changes if it's getting worse, and of course looking at the emotional needs. Observe. Observe the skin, do a thorough skin assessment, have them undress and look at all the moles, the warts, the birthmarks, ask them about sun tanning in tanning beds. How often do you get sunburn, especially in the summertime? Are you exposed to hazardous chemicals on your job? Physical assessment. Ask the patient to remove all their clothing, put on an exam gown, inspect and palpate. Look at the lesions, do a head to toe thorough assessment. Use your pen light, record and measure, and you need to measure all of the lesions and give accurate measurements. It's very important. Your nursing diagnoses: impaired skin integrity, deficient knowledge, risk for infection, hopelessness, anxiety, and these are not all. Our goals, of course, is to be able to describe the treatments available, the pros and cons. The patient will demonstrate no signs and symptoms of infection post-operatively if they've had surgery. The patient will conduct skin self-exams once a month. The patient will verbalize awareness of measures to prevent skin cancer reoccurring, such as proper use of sunscreen and clothing and limiting exposure to the sun. Your goals: addressing feelings of hopelessness, and we've already talked about that in another chapter, and it still applies here as well. And really teaching them. There's a teaching box on page 142. The patient with malignant melanoma. Teach them. Take care of your skin. Limit your, especially if you're fair skin, limit your sun exposure. Measures to reduce anxiety. And I do apologize for sometimes sounding like I'm off. I'm doing multiple things as I'm recording with the PowerPoint and my references here. So sometimes I'm just trying to match up things. So just bear with me, okay? Because I know it sounds terrible sometimes. And sometimes I do not mean to cough and sneeze while I'm recording either. I do apologize for that. But again, reducing anxiety. And, if it's caught early enough, then it can be treated. And of course, expected outcomes. Patient demonstrates no signs and symptoms of infection. The postoperative wound demonstrates signs of adequate healing, and sometimes it leaves a bead scar. Like I said, they have to go deeper sometimes. So the patient, maybe they have this bead scar on their face. And so, you're dealing with self-esteem issues. The patient avoided sun exposure. They didn't get in the tanning beds. They were able to describe indications for reporting skin changes, and they were able to cope. Thank you.